What do you see as the next breakthrough sort of global accomplishment that's going to happen in AML in the upcoming 5 to 10 years?
So I think one of the major things that hopefully will happen in the next coming years is for us to perfect how we use triplets with HMA venetoclax and how to maybe use more than one novel, like a novel combination, where hopefully in the future that will happen, especially now hopefully we'll have menin inhibitors. They're in the pipe, they're still in trials, but if the outcomes are as good as we believe and they make it to approval, we will then talk about even combining that with other other targeted therapies. And it's a good problem to have that we're going to have all these agents and know how to combine them, how to sequence. I think that's where we're going to be, that's a problem, which is a good problem to have that we're going to be dealing with in the future, very near future.
Daver?
I think that's absolutely true. I think we have a lot of tools that we can use optimally to really improve survival. The way, there's always a little bit of that difference in way a drug gets approved, showing a single agent improves CR/CRh and median OS by a few months, which is good because you have an option, but really we want to use these drugs to cure more patients, right? Having the median survival go from 5 to 9 is okay, but that's not what our patients are looking for, not us. So I think optimizing the upfront use of those drugs where we can maybe cure 10, 20, 30% more, like they're doing in ALL, multiple myeloma, other diseases, is one. And the second, I think, is what we really need is an effective immunotherapy. I think this is where we're behind, all the other heme malignancies, lymphoma now, ALL for a long time already, multiple myeloma. So, whether it's better ADCs, whether it's cellular therapies, CAR T, NK, and I think these are coming because there's a lot of the investigators and experts and pharma are very cognizant, and regulators, that AML does not have a immune therapy. So I think we will see in the future MRD-directed immunotherapy emerging, and I think that will really then push the survival up because we know we can debulk. We can achieve CR/CRIs in 80 to 90 to even 100% using the good triplets, optimal regimens, intensive chemo, whatever it may be. But it's really the durability in MRD that we need to get at. So I think in the next 5 to 8 years, immunotherapy has to come in to really push us to the next level. Yeah.
And one of the things that I thought of, and you led right into my thought, which was well planned, is that I think the concept of MRD is extraordinarily important. And I think one of the things that we will learn as we are better at determining what is true MRD, the question then becomes who needs further therapy and who doesn't need further therapy. So we have learned from standard MRD testing that we do now that oftentimes with NPM1, those patients don't need transplant. And so I think that's a huge step when you think about how many people 15 years ago we were taking the transplant, or without knowing MRD, there were patients we weren't taking the transplant that maybe should have gone to transplant. And I think that way of sort of differentiating who is going to be who needs to be a transplant candidate, correct, let alone are they a transplant candidate? But if they don't need to be a transplant candidate, we don't need to think about that. We don't need to think about all the things that we talked about and all the advances that we talked about in terms of what the benefits are for transplant and how great our colleagues have done, because they may not need it. And I think that's a very important concept that we need to try to determine for further steps and further manipulation of treatments is one way of looking at it.